Welcome to the Deep Dive. Today we are taking on Chapter 19, which is the absolute foundation for understanding pharmacology. We're talking about the nervous system.
The absolute bedrock. You really can't get how drugs work without this.
Exactly. So our mission is crucial. Before you can grasp how any drug works, from, I don't know, a simple pain reliever to a complex antidepressant, you have to get the body's wiring.
Right.
We're going to break down the structure, the electricity, and the chemistry. The goal is for you to walk away knowing exactly where the body is vulnerable to, well, to therapeutic intervention.
And that's the critical lens we're using. The text really emphasizes that the actions of the drugs we give, they actually teach us about these complex biological processes themselves.
So the drugs reveal the system.
In a way, yes. So we need to define the main building block, the neuron, and its two communication methods.
Yep.
The electrical action potential and the chemical messaging at the synapse.
Okay, let's start with the architecture. You've got the main control center, the central nervous system.
The CNS, brain, and spinal cord.
And then you have this huge network reaching out from there, the peripheral nervous system, or PNS.
Which is your data collector and your output mechanism. And that whole system is run by the neuron. That's the key structural unit.
Right.
It has a cell body, the soma, and then these two types of fibers. You have the short branching dendrites that bring information in.
Okay.
And then one long single axon that carries information away.
We can make that flow even clearer, right? With afferent versus efferent fibers.
Yes.
Afferent fibers are sensory. They bring information to the CNS.
From all your body's receptors.
And then efferent fibers.
Yeah.
They exit the CNS to trigger a motor response.
Yeah.
I always remember E for exit.
A good way to think of it.
Now, here's something surprising about this structure. Neurons are so specialized that they generally can't reproduce. So if you lose the nerve, it's just gone.
That's true. The whole cell is gone. But they aren't completely without repair mechanisms. The cell can't replicate, but the axons and dendrites, they can regenerate.
As long as the main cell body is okay.
As long as the soma and the axon hillock are intact, yes.
Which is why we see that classic clinical case, right? Someone crushes a nerve in their hand, loses feeling, loses movement. But because the nerve cell bodies are often safe up in the wrist or arm ganglia, that damaged axon can slowly regrow.
It's a very slow process, but it shows you the resilience that's built into the system. But resilience aside, this system it's incredibly demanding.
Let's get into that. The action potential, the electrical signal.
Okay, so when the nerve is just sitting there, quiet, it has what we call the resting membrane potential.
It's polarized.
It's polarized. The sodium-potassium pump is constantly working, using energy, to push positive sodium ions out and keep positive potassium ions in. The end result is that the inside of the cell is actually negative.
So it's like a tightly wound spring just ready to go.
Exactly. And the trigger is stimulation. That causes depolarization.
The signal.
That's the signal. The cell membrane suddenly opens up these sodium channels, and all those positive sodium ions just rush in.
And that flips the charge.
Instantly. The inside becomes positive. That sudden, super fast reversal, that is the action potential.
And that signal is instantaneous. But the system has to reset, or it can't fire again.
Correct. So repolarization happens. The sodium-potassium pump kicks back in and forces the membrane back to its polarized resting state. It reestablishes that negative charge inside. But the energy drain from this constant pumping is just immense.
It sounds incredibly fragile. I mean, if it's always using energy, what happens if resources get low?
And that's its biggest vulnerability. The nerve has to have a constant supply of oxygen and glucose.
The basics.
The absolute basics.
Okay.
And the right sodium and potassium balance. If you have anoxia and no oxygen or hypoglycemia, low glucose, the nerves can't run that pump. The whole system becomes unstable.
So you'd see irritability.
Severe irritability, or on the flip side, complete unresponsiveness. It's a critical safety point for any patient assessment.
Speaking of energy and efficiency, let's talk speed. The long nerves are myelinated. They're covered in this myelin sheath.
Formed by Schwann cells.
And this isn't just for protection, right? It's about making the signal faster and saving energy.
It's all about efficiency. The myelin wraps the axon, but it leaves these tiny little uncovered patches of membrane.
The nodes of Ranvier.
The nodes of Ranvier. And this is where the physics gets really cool.
Yeah, because instead of the action potential having to regenerate itself along every single millimeter of the nerve,
which would be slow and use a ton of energy,
the signal just skips or leaps from one node to the next.
We call it saltatory conduction, leaping conduction. It uses way less energy and makes the signal exponentially faster.
And that brings us to a huge clinical connection. Multiple sclerosis.
In MS, which is often an autoimmune issue, those Schwann cells swell up and they basically block the nodes of Ranvier.
So the signal can't leap
It
anywhere.
stalls out, and the patient starts to experience a progressive loss of function because that nerve response is just gone.
Okay, so we've got the electrical spark down. But how does that spark actually jump the gap to tell your muscle to contract? That has to be chemistry.
It is. The action potential travels down the axon, and it stops dead at the terminal. It literally hits a wall.
And that wall is the synapse.
The synapse,
Yeah.
the whole communication junction, you've got the presynaptic nerve ending, the synaptic cleft, which is just the space, and then the postsynaptic effector cell on the other side waiting for the message.
So what happens? The electricity arrives.
The arrival of the action potential triggers calcium channels to open. Calcium rushes in, and that influx of calcium is the signal.
The trigger.
The trigger that forces these little sacs, these vesicles full of neurotransmitters, to merge with the membrane and dump their chemical contents into the synaptic cleft.
And that chemical messenger finds its specific receptor on the other side.
Exactly. It binds to a very specific receptor, causing a reaction. And this is really where pharmacology finds its playground.
Right, because that signal can't just hang around forever.
It has to be reset
Yeah.
immediately. To get ready for the next signal, that neurotransmitter has to be inactivated or removed. And there are two main ways this happens. One is reuptake. The presynaptic nerve just sucks the messenger back up to be recycled.
Efficient.
Very. The second is enzymatic breakdown, where specific enzymes in the cleft just destroy the chemical.
And there's our general principle for pharmacology then.
Yeah.
Drugs mess with synapse activity.
That's it. They might block the receptor site itself, so the message never gets delivered.
Or they could interfere with one of those two termination processes.
Right. A drug could block reuptake, for example. That leaves more neurotransmitter sitting in the cleft, which amplifies the signal.
Or you could block the breakdown enzyme.
Like acetylcholinesterase or monoamine oxidase, you get the same effect, a stronger, longer-lasting message.
So let's name some of these crucial chemical messengers. Who are the big players here?
The text highlights 5 that are just essential. First, acetylcholine. Absolutely vital. It's the main communicator between nerves and muscles and a huge player in the autonomic nervous system. Then norepinephrine and epinephrine, the catecholamines. They drive the fight or flight response, the sympathetic nervous system, and they're highly concentrated in the brain's emotional centers.
So mood and stress.
Very much so. Then there's dopamine. This one is critical for coordinating motor function movement and also our intellectual responses.
Right, so a lack of dopamine is tied to movement disorders.
Exactly. Next is GABA, gamma-aminobutyric acid. This is our main inhibitory messenger. It dampens nerve activity, prevents overexcitability.
So things like seizures?
Precisely. Drugs that target GABA are often sedatives or anti-anxiety meds. And finally, serotonin. It's crucial for regulating mood, arousal, sleep, motivation. Like norepinephrine, it's all over the limbic system, making it a primary target for antidepressants.
When you look at that list, you realize any drug messing with one of those 5 isn't just treating one little problem.
No, you're affecting massive systemic functions. The scope of the challenge is huge.
Which brings us to the CNS itself. The brain and spinal cord are so sensitive, they need layers and layers of defense.
They do. Physically, you've got bone the skull, which is corrugated to absorb impact, which is clever.
Now, under that, the meninges, the stretchy membranes.
But the most important functional defense is the blood-brain barrier, the BBB. It's a semi-permeable boundary that keeps out large molecules, plasma proteins, many toxins.
And a lot of the drugs.
And that's the double-edged sword. It protects the brain, but it also creates a massive therapeutic challenge. Many great drugs, like some antibiotics, are bound to plasma proteins, so they're just too big to cross.
So treating a brain infection is really hard.
It's very difficult. You need specialized lipid-soluble drugs, and honestly, a lot of the time we're waiting for the barrier to fail a bit before systemic drugs can even get in.
The brain's blood supply is also a protective measure, right? The circle of Willis.
A remarkable bit of engineering. It's a common vessel that's fed by the carotids in the front and the vertebral arteries in the back. They all join up.
Creating a network.
A network, exactly. So if one major artery gets blocked, say a carotid artery, the circle of Willis can often reroute blood from the other arteries to that area. It protects the brain from immediate oxygen and glucose deprivation.
Okay, let's map the brain itself. Starting at the bottom, the most primitive area, the hindbrain.
The hindbrain is survival central. It contains the brainstem, the pons, and the medulla oblongata, and they manage all the non-negotiable vital functions.
Breathing, heart rate.
Respiration, blood pressure, swallowing, even the vomiting center. If the medulla is compromised, the patient is in immediate critical danger.
And the hindbrain also has the cerebellum.
Right, which doesn't start movement, but it coordinates it. Posture, balance, all that smooth, voluntary muscle activity.
Moving up, we get to the midbrain. Smaller, but still critical.
Very. It houses many of the cranial nerves and, importantly, the reticular activating system, or RAS.
The RAS is fascinating. It's like the brain's bouncer.
That's a great analogy. It gets billions of pieces of sensory data, but only lets the most significant stuff through to your awareness. And it controls our sleep cycle.
How does that work?
Well, when serotonin levels rise in the RAS, it slows down and shuts off. That's sleep. Then the medulla helps absorb that serotonin. As the levels fall, the RAS turns back on and you get consciousness and arousal.
A clear target for sleep aids, then.
And other behavioral drugs, yes. Finally, we get to the forebrain, the upper level where all the complex thinking happens.
So the cerebral hemispheres, the thalamus, and the hypothalamus.
The thalamus is a relay station. It takes raw sensory input, pain, temperature, touch, and sends it up to the cerebrum to be interpreted.
And the hypothalamus.
The hypothalamus is a major body sensor. It's controlling temperature, water balance, and it coordinates the endocrine and autonomic nervous systems.
Which brings us to what really makes us human. Emotion, learning.
The limbic system. It sits right above the thalamus.
And this is the center for the expression of emotions.
Anger, pleasure, stress, motivation, all of it. And it is incredibly rich in those three neurotransmitters we mentioned earlier, epinephrine, norepinephrine, and serotonin. This is the primary target for almost all drug therapy for mood disorders.
And at the very top, the cerebral cortex. Thinking and learning.
Exactly. The text notes the classic division. The right hemisphere being more artistic, forms and shapes, and the left being analytical language, numbers, processes.
And when we move, we use two systems.
Right. The pyramidal system for voluntary movement. But the extrapyramidal system coordinates all the unconscious stuff, like posture and your walking gait.
This is why some drugs cause those movement side effects, right? Like tremors.
It is. They interfere with that extrapyramidal system. And we also see the crossing of motor fibers here. The right side of your brain controls the left side of your body, and vice versa. Crucial for understanding the impact of a stroke.
Okay, let's decode learning and memory, short-term memory.
Is purely electrical. It's an electrical circuit called an engram, just a reverberating loop of action potentials.
Which means it needs constant oxygen and glucose.
Constantly. If that blood supply drops, that electrical loop is the first thing to go. That's why in those situations, people have to rely on their long-term memory.
And how does long-term memory form?
That's when the electrical engram becomes permanent. It actually creates structural changes in the cells. And this process requires oxygen, glucose, and crucially, it requires sleep to process and stabilize the information.
The text even points out that hormones play a role.
They do. Stress hormones, like ADH, can affect learning. A little bit of stress can actually boost mastery, but too much stress shuts learning down completely.
And it mentions oxytocin increasing learning.
Yes, which is why maternity nurses are often told that women in labor will remember very small details taught to them during that heightened emotional state. It's fascinating.
And we have to mention the placebo effect.
We do. It's a documented effect. The very perception that a drug will work activates the cerebrum and the limbic system, and that has a tremendous impact on the actual physiological response.
So a patient's expectations and emotions are inseparable from the drug's effect.
They are. Which brings us to the big safety point. Predicting how any one patient will react to a nervous system drug is extremely difficult.
Because the nervous system affects everything, and intervention's almost always going to be systemic.
Exactly.
So, to wrap up our deep dive, we've got the architecture, the neuron, afferent, and efferent flow. We've got the electricity, the action potential, depolarization, and the speed of saltatory conduction. And we've got the chemistry, the synapse, neurotransmitter termination, and those 5 key messengers.
And maybe the most provocative thought this chapter leaves us with is that even knowing all of this, the actual mechanisms of learning and how many of these drugs really influence human behavior, they're still not fully understood.
There's still so much to learn.
So much. We're really just beginning to grasp the true influence of pharmacology on the human brain.
But that framework gives you the essential lens you need for what comes next.
Yeah.
You now understand the mechanisms, the vulnerabilities, and the molecular targets that will come up in every single chapter that follows. Thank you for diving deep with us.
We'll see you next time.